nampak ni. On off kembali.
Ustaz boleh nampak Dr. Has tak?
Sekejap, I on off balik tak?
Okay.
Sekejap. Okay. Boleh nampak tak Zaid? On off dah. Ustaz punya suara pecah Ustaz.
Ustaz boleh nampak Dr. Has tak?
Saya nampak.
Kita orang boleh nampak.
Okay.
Alright. Saya tak nampak, tak apalah. Dah lama tak pakai Google Meet.
Tak apalah, dah selalu nampak.
Okay, kita start 10 sharp lah ni.
Boleh.
Okay. Assalamualaikum and a very good morning, everyone. We will start in 1 minute. In 1 minute time. Kita akan bermula dalam tempoh 1 minit lagi. Assalamualaikum and a very good morning, everyone. I'm Dr. Muhamad, your moderator for today. Welcome to our Fri-Date. Our Fri-Date for today is ethical dilemmas at the bedside, how clinical ethics consultation can help. So today we are aiming to introduce HASA and Faculty of Medicine staff members on the how can you ask help from clinical ethics consultation service. So before we start, let me introduce our speaker of the day, which is our colleague, Dr. Hazdalila Yais Razali. She is a medical lecturer in medical ethics and law at our Faculty of Medicine, UITM. Dr. Has holds a medical degree from National University of Ireland. She also has a master's degree in medical ethics and jurisprudence, a bachelor's in legal studies. She is also the first Malaysian to obtain diploma in legal medicine from United Kingdom, and has received formal training in clinical ethics consultation from Harvard University, and currently she is pursuing her PhD in University Malaya. She previously served as the head of medical legal unit at Hospital Ampang and is currently a clinical ethicist at Hospital Al Sultan Abdullah, where she coordinates the clinical ethics consultation service and chairs the clinical ethics committee. She also served as a member of the Malaysian Research Ethics Committee and sits on the disciplinary board of the Malaysian Medical Council. Today, she will be speaking on ethical dilemmas at the bedside, how clinical ethics consultation can help. Dr. Hazdalila, the floor is yours.
Right. Thank you, Zaid. Thank you for the kind introduction. So today, I would like to keep it simple, okay, so because this is Friday morning, and most of you are quite occupied with other activities as well. So thank you very much for all of you who are here. Basically, we want to share on I am representing the clinical ethics consultation services in large, a service provided by the Department of Medical Ethics and Law in HASA. So we are here to introduce on the consultation services, and also we are here to introduce on the clinical ethics committee, because the presence or the visibility is, I think it's not that great among the faculty member and also the hospital staff, right? So today we're going to talk on ethical dilemmas at the bedside and how clinical ethics consultations can help. If you remember during your orientation, we kind of like give an orientation or introduction, if you're a new member, if you're new staff, on how what is clinical ethics consultation and how are you going to refer to us and what are the process and everything. So today I'm going to zoom out a bit. Okay, we're going to introduce you on what are the ethical dilemmas itself, and then how we can provide our help. All right. So let's skip this one because I think Zaid has introduced just now. Okay, so today it looks quite busy slide, but actually we're just gonna make it kind of like simple as very casual like. Okay, so I'm going to talk to you into introduction. What are ethical dilemmas? Okay, why these dilemmas cannot be solved by clinical judgment alone, and what are ethics consultations or consultants, and what do we do, and what are the frameworks or what are the tools that we use, case studies, and of course benefits and limitations of our services. Right. So basically, when we say ethical dilemmas at bedside, so what do we mean by that? Okay, so ethical dilemmas include almost all, okay, but not exclusive to situations where clinically reasonable options, conflict with ethical values. You don't know what is right, which right is more right, okay. So it kind of like conflicts, do we want to continue the treatment for a patient who kind of like in vegetative state, or do you want to continue treatment who to a patient who is previously ADL dependent and currently in or a late stage of diseases and things like that? Do we want to provide that? Okay, so you know that doing for example, anything, okay, doing a task or doing a clinical procedure is a good thing, but somehow you feel that it is not really the right thing to do, or you feel that doing A is a good thing, but you feel that doing B is also a good thing. So you don't know which right is right, okay? So that is what we mean by ethical dilemmas. Okay, you are currently now in dilemma, okay? So often the case is that legal rules, professional duties, and of course patient wishes do not align to each other. Okay, so that's why you have this dilemma. If they aligned, then that's fine. You can continue with your clinical activities as normal. But we are talking about those situations or those scenarios where these rules or these duties do not align. Okay, so but these are not rare. Okay, if you go back to your clinical activities, if you go back to kind of like last week or last 2 weeks, right? If you scrutinize all the cases that you face or all the cases that you handle this week, sometimes there are um, dilemmas, okay, whether you realize it or not. There are some kind of conflicts between, not kind of like complaints, but conflicts of doing what is the right thing. Because dilemmas are not rare, okay, ethical dilemmas are not rare. It is not kind of like abstract, it's something that's very far, something that is kind of like very alien to you or things like that. No, it's really close to you, it's really near, and it's not just a philosophical exercise, or it's not something that is just a theoretical exercise. No, it's something that is very practical. It can occur anywhere. It can occur in the ICU, it can occur in the ward, clinics, ED, or any operating theaters at all. So why clinicians struggle with ethical dilemmas? Because you are always time pressured, and there's a lot of clinical uncertainty. There's a lot of emotional burden as well, and there's a lot of moral distress. When you want to do something, okay, for example, when you want to do something nice, okay, your virtual ethics, there's something that's embedded in you says that okay, you want to do something nice. You you know that is the right thing to do, but somehow the systems or the people around you doesn't allow you to do that. With this, when this conflicted, what you want to do, okay, we don't have to talk about other people, okay, we'll talk about yourself. All right, so what is your expectations, and what are the things that you can do? When it conflicts, you will have moral distress, and you will have kind of like emotional burden. If you go back into your services, if you go back into your activities, do you have uh, let me pose a question to you. Do you have a patient, or do you have a situation where you can't forget them, where you still remember them vividly, what happens? For example, I have a patient previously when I have a patient where the patient suffers MI. Okay, I know the best thing is to do PCI, or the best thing is to send the patient to a cardiac center, but then I can't do that because the patient cannot afford, the PCI, or cannot afford to travel. So what we can do is that just pharmacological, medications and things like that, but it's not definitive for sure. So the patient suffers a second MI, and of course the patient collapsed and died. So I can still remember vividly, I can still remember clearly how he looks, how the family member comes to me and things like that. The best thing, because at that time I know the best thing is to refer and to upscale, or do more, but because of these constraints we can't. you know so this leads to a lot of emotional burden. All these cases accumulate over time. You will have burden, and you will carry this extra baggage, not just because of your shift hours and things like that. Because of this moral distress, you will have more burden that will lead to burnouts, things like that, right? So you will also have conflicted expectations from patients, families, colleagues, institutions. The institutions pressing you on do something that will be cost effective, cost efficient. Your colleague says that you want to do something. Colleagues expected you to do something, but a family member expected something else. Um, the patient is expected to do something else. Of course you cannot satisfy everybody, but with these conflicting expectations, you will have this ethical dilemmas, right? And of course, when people who are not familiar with ethics training or structured support, then you will have struggles to handle or to resolve all these dilemmas. All right. Okay. For example, this dilemma is not a kind of like a new thing. Okay. So it's prevalent in everywhere. In everywhere you work, it's always kind of like common in practice. Okay. So this I would like to give an example of this situational power and role morality. So there's a kind of like experiment, a psychological experiment dated, I'm not sure when, but then it was called a Stanford prison experiment. So this psychologist wanted to see, this is of course classified as unethical. Okay, I'm not promoting this experiment, but kind of like we can get the gist of it, or we can get the findings out of it, right? So what happened in this experiment is that they subjected healthy individuals to a prison environment as a warden. Okay, so these healthy individuals, these healthy subjects, these normal subjects, they are kind of like normal people, baik ni orang, okay? So, but then when they are exposed to harsh violence attitude of the other um, prison guards, okay? So at the end of the day, at the end after 5 days, these healthy individuals or these healthy normal subjects become more violent, okay? Because they see, hey, everybody is doing that, everybody is doing that, and that is the way for them to survive, So they are now copying, okay, something that even though they objected it before, but now they are copying it because that's the way you survive. All right. So um, the core finding is that people rapidly internalize rules, okay, and behavior that they will normally reject simply because the system permits or encourages, okay. But of course, we're not saying that people are bad or whatsoever, okay. So ethical failure often emerges from the system itself, not bad individuals, because most of you, okay, I can say everyone who becomes a healthcare practitioner, most of them have a good virtue ethics, have a good ethical principles. Okay, so if not, you're not here to help people, right? Okay, but then there are a lot of system failures or circumstances, that pushes you to lead to different or bad decisions, So ethical failures, we call that. So why this matters clinically? Because the healthcare rules shape the behavior, Sometimes when you are in different roles, okay, you do something, okay, but then when you go into another setting, for example, let's say when you are in medical, you say something, okay, but then when you go to ICU, you say different thing, because you say, this is how ICU works, this is the hospital policy. That is not my role to question, or that is not my up to my jurisdiction, or that is not within my power to change something. You tend to follow the system, or you tend to follow what is norm, right? But what is norm may not be the right thing. Okay, so normalizations of non-consensual procedures, okay, and it will lead to withdrawal of empathy, right? And sometimes you will have kind of like moral numbness, okay, in high intensity settings. For example, you see that nowadays, if you see that, it's not, it won't trigger you anymore. I mean, not anymore. It won't trigger you that much, okay, compared to your first day of work when you see that, So these are called moral numbness, or kind of like numbness, per se. So with all this, you will heighten, or you will worsen the ethical dilemmas. Right. And then You also And then you also have kind of like bystander effect or Javanese syndrome. Okay, this is also another psychological theories is that the bystander effect refers to social psychological phenomenon where individuals are less likely to offer help to a victim when other people are present. Okay, so this kind of like syndrome or this kind of like theory emerges after the real incidents of murder of Kitty Giovanni's in 1964 in New York City. You can read on it if you want. But this case lead to public uproar, and this psychologist Dali and Latin can like do a systematic study on what are these syndrome. Right. So the thing that I say is that the more people involved in a scenario or in a incident, then the less likely any one of you will act, because in complex teams, people will say that tak apa, someone else will speak up, ethics committee will handle it, or maybe you can say the HOD will handle it, or if you have some issues or you have some dissatisfaction, you say that, oh, never mind, we can sort it in the family meeting later, or the MDT will see it, or the other the other discipline will look at it or will handle it, right? So this will lead to more problems. Okay, so you will have kind of like delayed DNR discussions. You do not active resuscitation discussions. No one initiates capacitive assessment, because you said that, okay, for example, you have a case, maybe acute delirium, right? So you want to go for surgery, okay? You want to take consent, but you're not sure whether or not this patient sedar atau tak sedar, kan? But then when the patient looks like maybe the patient is okay, can understand all the instruction and things like that, you assume that the patient has capacity, but no one initiates a proper capacity assessment, kind of thing, because you feel that, oh, this is something that surgery will do because they are the ones taking consent. But the surgery thought, oh, this is medical will do, this is something that medical will do, and things like that. So this bystander effect will make the dilemma worse, will make the ethical failure worse, okay? Because at the end of the day, ethical paralysis increases with team complexity. All right, so you have a lot of dilemmas, okay, whether you're not, you realize it, okay? So these are the common ethical dilemmas that I can highlight. For example, decision-making capacity and consent, okay, about refusal of treatment. For example, when the patient came in to you, for example, infected toe for secondary to diabetic mellitus, right? So you feel that, oh, infected toe, you need to cut off ring amputation or whatsoever, okay? So if people who agrees to it, then you say, okay, never mind lah, straightforward lah, just go ahead and go for surgery. But for people who refuse it, and then you start questioning, hey, why are you refusing the right thing? Surgery is the proper way for you to manage the infected toe. Why are you refusing it? And then you start to say, do you really have the capacity? Do you really understand it? And you start thinking, that is the right thing to do for say, betul. But then, do you see that there's a pattern in when people start denying you, or when people start disagreeing with you, then only you go and ask, oh, whether or not this patient really understands what's happening. So that's a problem when you take consent. Okay, so for example, consent with makcik or pakcik yang macam agree saja, setuju saja. Okay, pakcik, saya nak potong kaki, setuju. You don't question that whether or not the patient really understand. Okay, so whatever happens is that you don't really understand, or you don't really assess, or you don't really evaluate whether or not that consent is properly informed. Okay, so that is also a problem. Okay, but now we go into refusal of treatment. So when you have refusal of treatment, you feel that, hey, this is the best thing to do. Medically, the best thing to do is to chop it off. But now, why are you refusing it? Okay, so that is also a dilemma lah, kan? Right. And then fluctuating or borderline capacity. So now patient came in with delirium, don't know, like sepsis, sugar high, whatsoever. So now you question whether or not the patient can make consent or cannot make consent. Okay, patient has a history of psychiatric illnesses, but now patient is in relapse. But because of the illnesses, because of that history, so you don't know, betul ke dia ni faham apa yang cakap, right? Okay, so that are also dilemmas, right? And then you have uh, again, when patient choices appear unwise, is that the right thing to do? You have dilemmas between best interests, and also you want to respect the patient's autonomy, but no, this is not the best thing to do. So what do you want to do now? Do you want to chop it off, or do you want to respect for patient's autonomy and things like that? All right. So end of life and limitation of treatment. Okay. You want to know when you can withhold, what are the differences between withholding and withdrawing treatment, when you can do that and when you can't do that. Fertility, medical fertility, DNR decisions, ICU triage, resource allocation, and things like that, right? And so professional integrity also tend to happen in terms of being asked to provide treatment believed to be harmful. For example, maybe sometimes patient comes to you and say that, okay, doctor, I feel that my nose is too big, right? So I want to do something aesthetic surgery to correct this nose or this presentation. So you feel that it is harmful. It is not wise to do that, but you have to do it because you're a plastic surgeon and you're paid for that. You Those are the things. For example, maybe you feel that there's no need for you to do cardiac marker for this patient, but because the patient is very anxious, the patient is very anxious and say that, oh, now the pakcik, makcik, auntie, second cousin, whatsoever have the cancer history. Are you sure I'm not having any cancer whatsoever? Eh, if anything happen, I'll sue you. Then you go, okay lah, I will just order the cardiac markers, the cancer markers. So you start going for defensive medicine. So those are the things that you feel like, normal lah. These are the things that you face daily, but this is actually a ethical dilemma, so, right? If you can handle it well, then that's fine, but sometimes it becomes so conflict or so complex that you don't really know what is the right thing to do, right? Okay, for example, there are a lot of cases, but I choose this case, Terry Schiavo in USA. This case occurs from 1990 to 2005, the span of 15 years. So in February 25, 1990, this young lady at the age of 26, she collapsed. She collapsed at home, following a cardiac arrest. Somehow this is linked to severe potassium imbalance, lah. But even though she is revived, but she suffered massive oxygen deprivation, lah. So HIA, leading her to a persistent vegetative state. All right. So the husband requested withdrawal of feeding tube, while the parents objected. Okay, so macam dengar macam selalu kan. Okay, but now the ethical issues in here is that what are the things that we can allow withdrawal, or withholding treatment? Okay, so the basic question in this case is that this starts from who is the legitimate surrogate decision maker. Are the husbands the legitimate surrogate decision maker? So if the husband requests withdrawal, why does the parents, why does the patient, why does the physicians have to listen to the parents, when they are legally married, So why can't the healthcare workers or healthcare providers just listen to the husband and withdraw the feeding tube? Why do you still have to consider about the parents? So this may be in US, but what happens if it's in the Asia spot, in our part, in our country, where the cultural sensitivity is higher? You will have, I don't know, but I do face, historically, previously, before, I do face this with husband, he can make his own decision about his wife or whatsoever, but then sometimes his decision is also influenced by the in-laws, right? By the brother-in-law, by the parents-in-law, not talking about the kids, about this in-laws, when legally they are married, and legally maybe by right he should be the surrogate decision maker. But what stops that? What makes that change? And then how much weight should be given to prior wishes? So the husband told that Chavo had expressed prior wishes, but it is not documented. So how much weight should be given to prior wishes, undocumented prior wishes? How can you testify? How can you justify? Or how can you prove that that is the right thing? And it's artificial nutrition. And the third one is that it's artificial nutrition is part of a basic care or part of medical treatment. It looks simple, feeding tube, but then feeding tube, is that basic care? or is actually a medical treatment. You count the calories from when you give something from through the feeding tube. You count the calorie. You want to take. You ask the nutritionist come in to find, okay, what is the protein intake, what is the carbohydrate intake, whatsoever. So when you're counting on all these things, taking all those things into consideration, are they a medical treatment, or actually are they a basic care? So when you say it's a basic care, so can you withdraw a feeding tube? When you say that it is a fertile, when the patient is already in persistent vegetative state, you start withdrawing treatment because you say there's a fertility, medical fertility. But then this feeding tube, are they actually a basic needs, or are they actually a medical treatment, So these are the questions that we feel that, hey, simple the questioning. But when you dip it and when you scrutinize all these problems, it actually um open a Pandora box, that sometimes people say that, why do you have to open that Pandora? Why can't you just leave it there? Why can't you just simple je lah, kalau ada, kalau tak ada, tak ada, But this is all interlinked. Okay, this is all about rights. This is all about patients' right, patients' benefits, and patients' interests, and also the healthcare interest as well. So even though you don't want to disturb this Pandora that much, but sometimes there are things that you need to consider and you need to question things, to make the healthcare systems more justifiable and more fair lah. Okay, so if that is the case, it happens in your, maybe you kata macam someone very far, something yang macam jauh sangat. But what happened in COVID? Okay, I hope that everybody still remembers it. It's a quite a catastrophic time, kan, have COVID-19 pandemic. So by that time, we have problems with ventilator scarcity. We have problems with ICU admissions. We have problem with hospital admissions, right? We have competing critically ill patients. Which patients is more ill? Okay, you also need to have a rapid triage decisions, right? Which patient should be prioritized for ICU admissions? Which patient should be prioritized for ward admissions, right? All those things, are actually, these are public health dilemmas, lah, right? So who get access to life-saving treatment? When the government decided, okay, there's a vaccine available, who gets the vaccines first, right? All these questions are also ethical dilemmas, lah. Why do we choose healthcare professionals to be the among the first vaccines receiver? Have you ever curious on that? If the vaccines prove not effective, are you asking, or are you jeopardizing? Aren't you not jeopardizing the healthcare system? By asking the healthcare practitioners to be the first frontliner to accept the vaccines when you don't even know, or you don't even for sure what are the efficacy of those vaccines, right? Okay, so these are all the dilemmas at the public health interest level. Okay, so so why these dilemmas cannot be solved by clinical judgment alone? Most of the people say that, tak apalah, kita, we know what other things to do medically. So why do we still need to consider these things ethically? Most of the time when you do something that is medically right, when your clinical judgments are correct, it's supposed to be ethically correct as well. Fair enough. But I would like to challenge that in saying that medical facts does not equate to ethical justification. All right. When you say something that is clinically appropriate, it does not mean all the time, okay? It does not necessarily means that it will be ethically acceptable as well, right? And then law sets some minimum standards, but not the moral ideals, okay? If you say, oh, according to law, okay, as long as I'm not negligent and things like that, but law sets some very minimum standards, okay? Law is the land where everybody stands on it, okay? If you fall below it, then you breach, negligence, whatsoever. But then, what are the best thing? Apa lagi you boleh buat for these patients? Those things are not decided are not decided, in black and white. Those are kind of like moral ideas. In moral or ethicals, it it is kind of like the sky. You can do as much as good as possible. For example, apa nama, in CPD kan, for CPD points, you have to have 20 points for your CPDs, right? So some people join, for example, a Friday again, okay, for a way for you to accumulate your CMEs. So some people say, okay, so that is the bare minimum lah. So once you have this, maybe you can have what, 1 points, 2 points, fair enough. But then that is the law. Okay, that is the standard. Okay, everybody join this, you will have 2 points. But for those who are more ideals, or for those who are more ethical, or for those who are more, better, so they will start focus. They will focus. They will start to digest all the points. They will start questioning things. They will start thinking. They will start, all those things lah. And some even take notes and things like that. Okay, but for those who just listen, for those who kind of like just open, apa nama, buka phone lepas tu letak atas dalam poket, atau buka phone letak atas meja, are they legally wrong, or are they ethically wrong? Those things. So clinically appropriate doesn't really mean that ethically acceptable. There are gray zones that are inevitable, right? And guidelines do not cover every context or nuances. So there's also risk of informal decision making. For example, there's a lot of inconsistency, right? For example, if you say that, okay, depends on consultant A, Prof A, dia akan macam dia lebih family ataupun dia lebih suka this one, so dia akan buat macam ni, so but then Prof B ataupun Dr. B, dia akan buat macam ni. There will be a lot of inconsistency, okay, in clinical judgment, in clinical care, of what more ethical decisions, right? You will have your inherent bias, okay? A lot of us, well, even though we try to avoid it, you can't really deny that you will have your inherent bias. For example, biases like, I don't know, I like someone who smiles a lot. I will have those biases for those who kind of like muka manis, muka senyum je kan, rather than someone who have a resting beach face, kind of thing. All these biases, it's something that you can't really avoid it, but it's something that is really inherent in you, and without you realizing, biases will affect or will influence how you make decisions, right? And paternalism, of course, these are the thing that is common and very prevalent among the healthcare practitioners, because you feel that, oh, no, I'm the doctor, or I'm the healthcare practitioner, so I know best what to do. So this is totally wrong, but there are still people who feels like that. Okay, so these are why the clinical judgment alone cannot really solve all these dilemmas. Okay, so for example, I give you an example. A 92-year-old patient with end-stage dementia. Okay, dementia is the only problem, but then recurrent aspiration pneumonia. Okay, he has no advanced directive. He's still ADL independent. Okay, but just that he has a end-stage dementia. So family members demands everything need to be done, right? And medically, intubation and ICU care are technically possible. You have a lot of ICU beds available. Survival to discharge kira-kira macam memang walaupun dia recurrent aspiration, but very mild, so the survival rate is very high. Okay, so if you follow the standard of care, it allows for escalations of therapies. Antibiotics boleh bank, because the kidneys are well, so you can bank all those antibiotics and other things lah. Okay, but then the question is that, is it not you will prolong suffering? Okay, does the patients have a meaningful recovery? What do you mean by meaningful recovery? When you say that, oh, there will be no meaningful recovery, or are you sure of that? Or you say that, oh, there will be a recovery and it will be meaningful because the patients still have time to spend with the family member. Those are the things that, even simple terms like meaningful, how sure are you that it is a meaningful, or how sure are you it is not meaningful, right? Disproportionate burden. Maybe as a family, and maybe as a practitioner, you say, oh, patient is dementia, selalu hilang, selalu rata-rata. This will be a burden to the family member. But the family member says, no, that was fine with us. Why do we want those maybe practitioners say, why do you want to go for all this extra unnecessary things? But the family member wants different thing, because the value value that you hold are different, right? Even though you sama-sama Islam, sama-sama Christian, sama-sama Buddha, sama-sama whatsoever, okay, even though your religion say something, but still the values in you are different, okay? So um the key question is that if we can do it, if we can admit the patient to ICU, if we can ventilate the patient, intubate the patient, ventilate it well, but must we do it? If you play chess, there will be a lot of steps, or there will be a lot of times when you can attack the king or you can attack the pieces, but do you have to do it? Must you do it? Because if you keep that attack, maybe you will you will have a bigger attack, kind of like thing. The question is that just because you can do it, but must you do it? All right. So another example is that in this case, in baby doe regulations 1980s, okay. So at this time in John Hopkins Hospital, so there are situations where Down syndrome babies with congenital anomalies, esophageal atresia, right, were left to death or left to die because they said that, or they have Down syndrome, and these are the kind of like the hint from God to say is that they are not compatible with life. So there's no need for you to do this surgical correction, even though it is possible to do surgical corrections because they might have a long-term kind of like disability. All right. So the surgical correction was not done, and baby dies. Okay. So this caused uproars as well. So the US have a baby doe regulations which says that protections for disabled newborns lah. Okay. So they say that even though even though the babies are disabled, you can't make decisions just because they are disabled. All right. So in contrast, all right, that was in 1980s. But in contrast, in Charlie got case in UK 2017, right? So this infant with mitochondrial DNA depletion syndrome is very dependent on ventilator because they don't have mitochondria. Not they, because this baby does not have mitochondria, so they cannot breathe on its own and things like that. All right. So in UK, there's no treatment. Okay, so they are talking about withdrawal therapy, lah. But then the parents, who refuses to let go of this child, did their own research and they found that there are experimental nucleoside therapy abroad. Okay, so now they are requesting to transfer the child from UK to the other country so that they can have this experimental therapy. Bear in mind that this is an experimental therapy. So the treating team judged that this treatment is futile, okay, so there's nothing much that you can do based on the current science, and then this is experimental nucleoside. You might cause more harm to the patient, and the travel itself might cause more stress for the child. Okay, why do you want to subject the child to more harm or danger? Okay, so these are the cases that you cannot be solved by just clinical judgment alone. Okay, because you say that when clinical judgment in Charlie Cut, because there's no more treatment available at that time, so you don't have to do anything. But then, there are experimental therapies abroad. So what are you going to do? So that's why, in certain cases, clinical judgment alone cannot resolve the problem. Again, I pose to you: if we can do it, must we do it? Okay, is it a must that we still continue whatever that we can do? Okay, so now coming back, not coming back. So now we're going to introduce you on what is ethical ethics, clinical ethics consultation. Okay, so basically it's a structured process lah. To firstly we need to identify. Okay, so there won't be a problem if you do not know that there is a problem. Then okay, so but ignorance is not a bliss. Okay, just because your eyes can't see it, it doesn't mean that it's not there. Okay, so you need to identify ethical issues for you to manage the case better, right? You need to clarify what are the values involved and what are the obligations involved. Okay, and then you need to support the ethically justifiable decision making lah. Okay, so ethics consultation is not policing clinicians. We're not here to say, oh, you have to do this, you have to do this, you have to do that, you have to do. No, we are not going to do, and we are not ever, that's not a practice, or that's not the way we go. We're not policing clinicians, okay? And we're not here to replace the clinical judgment. Clinical judgment is a way, is for you to decide. But now we are saying is that what are the right thing to do, okay? And again, we're not making decisions for the team. The team is still the owner of the decisions, okay? And ethics is not just for big or dramatic cases only. It can be for your daily cases, or simple thing where you're sometimes, you can always refer to us. Because at the end of the day, what we want is that we want to improve the patient-centered care. We want to reduce the moral distress among the healthcare practitioners, so that you will reduce your moral your word out, right? We want to enhance the ethical consistency. We don't want to say that, all the doctors in Hasab, we want to do the best, the ethical kind of thing. Not because, sometimes doktor ni buat macam ni, doktor ni buat macam ni, doktor ni buat macam ni. We're not talking about clinical judgment. We're talking about the ethical judgment, right? Okay, and then we also want to strengthen the transparency and also the accountability of each cases, each decisions. So we start with when, right? So when should a consultation be requested? When there is a lot of persistent disagreement. Asyik tak puas, bukan tak puas hati. Asyik macam tak ngam. Rasa macam when you do something, you feel that something's still missing there. There's a lot of persistent disagreement. You have a lot of uncertainty about decisions, not just capacity or concern, but the decision itself. You have a lot of conflicts between values and treatment plans. The staff nurse are saying something else, the doctors are saying something else, the MAs are saying something else, and part of the ethical thing. Doctor, we have to do this is more beneficial, ataupun this is ni lebih baik untuk patient, you have to do. But the doctors are saying something else. There's a lot of conflicts, disagreements between the team, in the team. High stakes or irreversible decisions, something that you feel that very irreversible. For example, like withholding or withdrawing euthanasia or whatsoever thing, So who is involved? Who can refer anyone, right? But who is involved in all the consultations? It's not just the ethic, it's not just us, but it's also the treating team, the patient and family member, of course, the ethics consultations, the consultants, the clinicians, ethicists, or legal advisors where relevant. Okay. Again, we are kind of like the mediator. We're kind of like the third party, discussing or mediating or facilitating the communications between either the team or the patients, or either between the team itself. We are not to kind of like oversees the discussion. We are not there to decide for the teams. We are just there for a mediator. If you understand what the mediator is, that is only the third party who facilitates the communication. Okay. Often the problem with our healthcare is about the communications. Okay, miscommunication. There are a lot of misalignment in goals of standard of care or goals of therapy or whatsoever. It's all due to miscommunication. Okay, so we're there just to mediate the communication, facilitate the communication, so that everybody agrees or everybody realize everybody have different values. Bring all the values on the table, and we start discussing and deliberating on what is the best thing to do. All right, so that is what we do. Okay, we kind of facilitate the discussion. All right, so typical consultations processes starts with, of course, a case referral. So anybody can refer. Okay, not just the doctors, not just the consultants. Any one of you, either your MA, staff nurse, technicians, whatsoever. Okay, you can refer. All right, and then you will call those who are on call. You will clarify facts again, and we'll clarify who is involved. Clarify facts and stakeholders, and then we will identify the ethical issues. There are calls that we receive that is more kind of like legal problems, ataupun more kind of like the complaints, or the family member not complain. And that one is, I think, complaints is beyond us lah. So what we do is that before it comes complaint, before it becomes a legal issue, let us mediate or let us facilitate the discussion or communication, right? And then kalau bila ada problem tu, that nasi sudah menjadi bubur, right? So and then we do the ethical analysis using principles and frameworks, and then we do documentation, of course. We give recommendations, and of course we do follow up if needed. All right. Okay, so there are differences between clinical ethics consultation service and also clinical ethics committee. Okay, so that's why just now during the introduction, Zaid mentioned both. Okay, because there are differences between the two service or between the two entity. So the clinical ethics consultation services is basically targeted, right, ethical support for individual patients. Okay, so it talks on what should we do in this case now. Okay, compared to clinical ethics committee, is more into the institutional ethics oversight and governance. Okay, it talks into what should our hospital ethical standard and policies be. Okay, what should we do? Okay, if we are having problem with people with the consent, what are the policies or what are the recommendations that we need to do? Those are the things that is deliberated by the clinical ethics committee. For clinical ethics consultation services, we ask on what are the active ethical dilemma in the ongoing patient care. But the committee maybe we do on something that's retrospective, right, or something that is recurrent. Almost like every department have this problem. So then we're going to look into what actually, what kind of policy that we need. Okay. Activities, a lot of CECs, a lot of CEC involved in policy drafting, guideline review, ethics education, and also institutional advice. But clinical ethics consultation services involve ethical analysis, mediation, bedside discussions, documentation, things like that. All right. So now what are the frameworks that we use in ethics consultations? Okay, so you can either have substantive framework, okay, where the framework uses a set of key ethical values to guide decisions, or you can have procedural framework. Okay, the approach focuses on how decisions are made, not on fixed set of values. Okay, I include this to introduce to you or to let you know how we work. Okay, so sometimes people say, when we refer to you, so how do you kind of like come up with a decision or come up with the recommendations? How do you think? What are the tools that you use for that come with the recommendations? If we refer to Zaid, will it have different outcomes? If we refer to myself, if you refer to me, will it have a different outcomes? If you refer to someone else, maybe the Taimi or the Tamna or the Astrid or the leader, will you have a different outcome? Okay, the answer is no, right? Because as much as possible, clinical ethics is about science. Okay, so if you talk about science, it's something that is reproducible. It's something that is very objective. It's not subjective. So regardless, even though if I have my own biases, if I have my own preferences, in coming out with the deliberation or in doing the deliberation or coming up with recommendations, okay, we also use an objective or we also use a framework or tools that we use that will lead to a very objective recommendations. Okay, as much as like you using your stethoscope to listen or to attenuate the lung sounds or heart sounds, we use our frameworks to attenuate all these ethical issues and problems. Okay, so you can either have substantive or procedural. So I need to rush a bit lah. I think I'm a bit delayed. Okay, so for ethical frameworks that is substantive, that is very common, is four principles of medical ethics. Okay, so you have respect for autonomy, beneficence, non-maleficence, and justice. Okay, so these are quite common lah. You always use this or you always have this. Okay, which are something that is very you selalu dengar. Okay, so in this case, for example, Mrs. Y is a 56-year-old and has a learning disability. She is admitted to hospital with an ovarian cyst, and the cyst is blocking her ureter, and if left untreated, this will result in renal failure. Mrs. Y would need an operation to remove the cyst, but Mrs. Y has indicated quite clearly that she does not want a needle inserted for the anesthetic for the operation to remove the cyst. She is uncomfortable in a hospital setting and is frightened of needles. The clinician is concerned that if the cysts are not removed, Mrs. Y will develop renal failure and require dialysis, which will involve the regular use of needles as well, and be very difficult to carry out given her fear of needles and discomfort with hospitals. Right. So an anesthetist is concerned that if Mrs. Y does not comply with the procedure, then she will need to be physically restrained. Mrs. Y's niece visits her in the care home every month. The niece is adamant that her aunt should receive treatment. So the ethical issue is that should the surgeon perform the operation despite Mrs. Y's objections? All right. I do not have time to go through one by one. Okay, but if you go for substantive framework, yeah, you go for 4 principles of biomedical ethics, you will start analyzing the case, okay, according to the principle one by one. So you ask the what is the what are you going to do to respect for autonomy? What are you going to do to beneficence? Benefits of acting beneficently will need to be weighed against the ethical wrong feeling to respect for Mrs. Y's autonomy, right? So, and then you also think on non-maleficence, which is do no harm, right? How successful is the operation likely to be? Sometimes you have operation that that can go wrong. So even though you mean good, but it could lead to more harm, right? So how is likely that it is Mrs. Y will comply with dialysis? Those are the things that you need to ask, and also justice, lah. So consider the cost effectiveness. Which is more cost effective? Treating the cyst or leaving the cyst on that lead to renal failure that lead to dialysis? Those are the things that you would ask. Right. So this matter involves moving back and forth between the moral belief and judgment, right? The principles and background for other ethical theories. So basically, we want to balance and we want to achieve the coherence of those situations. So the other way is that you go for 4 quadrants. So these are quite the common that we use, that I use. I prefer these 4 quadrants. So what we have is that what are the clinical indications for these patients, okay? And then we go for what is the patient's medical problem, history, is it acute, what are the goals of treatment, probabilities of success, all those questions. And then you go for patient preferences, what do the patient wants, what are the, what is the right that patients choose, and whatsoever between the patients, okay? And then you go on the quality of life, okay? So what are prospects with or without the treatment, okay? That's part of the example. And then the contextual feature, are there family issues, that might affect the decisions, okay? And then if you go, that is substantive, if you go for procedural, right? So you will have this is part of example, either ATOX approach or ABCs. Okay, so I go for ATOX. ATOX is from Oxford framework. Okay, so it puts in 11 progressive stages to work through when deliberating about the case. So the first thing is that what are the relevant clinical and other contextual facts? What would constitute an appropriate decision-making process? Who is to be held responsible when the decision have to be made? List the available options. What are the morally significant features of each option? What does the law and guidance say about these options? What are the moral arguments in favor or against? What are the arguments valid? What are the foreseeable consequences and things like that? Identify the strongest counter argument. Can you rebut this argument? What are your reasons for that? So, and then you make a decision, okay? And then you review the decision in the light of what actually happens and learn from it. So if you feel that when you talk to maybe for example, maybe someone else, okay, for ethics, you feel that, oh, this person goes for more into a procedural, go for into carrying more into practical, but then maybe myself goes into more into the 4 quadrants. You feel that lain kan, nanti itulah ethical deliberation can be very subjective depending on who received the referrals. But it's actually no, it's actually the tools that we use. But at the end of the day, at the end of the day, the recommendations will kind of like come up almost similar, okay, because it's something that is always reproducible, okay. So the tools are different. So the way you construct, the way we construct the arguments, or the way we think about the cases might be different because of the tools that we use. But at the end of the day, the recommendation should be the same. Okay, so benefits of clinical ethics consultations. So for patients and families, of course, it's something that people hold, or that something that will protect or respect their dignities and also values. Okay, it will give them clear communication. When clear communication, indirect benefit, they will have reduced conflict. Indirect benefit, you will have reduced complaints. Indirect benefit, you will reduce your legal suits and things like that. The point is that you need to resolve the conflicts. You are these ethical dilemmas akan lead to macam tak puas hati. There's something missing. There's something, all this something missing. When you accumulate all this something missing, and then you will lead to dissatisfaction. You will lead to complaints. When these complaints are not managed properly, again, that this will lead to a legal suit. So we want to avoid these complaints and legal suits. So you start with the basic thing first. Is that you respect values. You have clear communications. Okay, so with this, all this, this risk mitigation, what are the way for you to mitigate all this risk or all these nuances, is for you to have a clear communication at the first step. So by referring, you will invite us in. So we are the third party who kind of like mediates the communication and mediates, kind of like put all the values on the table and see what is important for you and what is important for the patient. And then we put the values aligned. Okay. So for clinicians, we will be there for support you morally. Okay. And hopefully when your morale is protected, your morale is in place, it will lead to reduced burnout and distress. Okay. We are not blaming game. Okay? We are not here to play the blaming game. Oh, you salah, you salah, oh, you spotted what? No. We are here to to reduce all those questions. If you say, okay, you do something, so we start deliberating. Why do you do that? Why is there any other options? All those things. Okay, and then when you deliberate more, you will have shared responsibility. Okay, you don't have to hold the burden on your own. Okay, you will have a shared responsibility, and also of course you will have legal and professional protections, because these are something that is deliberated in something that you have looked into it. So you have looked into it from different angle. Okay, it's not an ad hoc decision. It's not a spontaneous decision whatsoever. It is something that you put your heart and soul into it. So you will have that protection now, because this is not kind of like subscribing decisions. Okay, so for institutions, of course, you will have improved governance. You will have risk mitigation steps. What are the things that I said just now? And then when you have referrals, okay, you will also identify, oh, these are the loopholes. So these are also steps to mitigate all those risks in healthcare system. Okay, so when you have this dilemma, you will know, or you will identify, oh, this is actually loopholes. These are actually something that is not patented, something that is not covered. So you will reduce your risk overall. Okay, and then you also have ethical culture building. So basically, everybody is doing the right thing. So you have a happy patient, you have happy staff, you will have a happy organizations, right? So that's all the benefits. But the challenges is that, of course, limited awareness and access. Okay, perceptions as ethics is non-clinical. Why do we refer ethics? This is something very clinical. Why do we have to refer something to ethics? Who talks on philosophies and things like that? No, clinical ethics is different. Clinical ethics is about application to it. Of course, there's a lot of resources constraint, but as for now, we're good. Need for context sensitive models, of course, but almost all are culturally sensitive, so it's not really a problem. Okay. So as a conclusion, ethics consultations is as a clinical skill. You can look at it as a clinical part, a part of your clinical management. It's not a luxury. It's not something that's very rare. It's not something that's very hard to achieve, or only apa dapat bila tempat-tempat yang diperlukan saja. No, it's something that is really real, something that is very near. Okay, so ignoring ethics does not make dilemmas disappear. Okay, ignorance is not bliss. So clinical ethics consultation supports better decisions, protects patients and clinicians, and of course strengthen the professionalism. All right, with that, thank you.
Thank you, Dr. Has, for the enlightening talk. So we now open the floor for questions. If you have questions, you can type in the chat box or you can raise your hands. So Dr. Has, to start the ball rolling, maybe I can ask you a few questions. How do HASA staff get in touch with the clinical ethics consultants?
All right, so basically we have our on-call rosters. It's uploaded in the OpenKM system. Okay, so you can see who is on call on that day, and at the bottom of the rosters there will be an individual phone number. So basically, if you see I'm on call, then you can always call me, and then we will discuss the case over the phone. And if it's really an ethical problem, or ethical issues, then of course will accept the referrals, and we kind of like up to you as well. So whether you just want to deliberate or you just want to discuss the case over the phone, or you want us to involve in the family meeting, MDT meeting, no, it's up to you. And then you will need to refer, or you will need to make a referrals in the Unimeds. Okay, there is a column at the left hand where you make a clinical ethics consultations referral, and then we will put in the apa nama, the response or the feedback in the same form.
Okay, so the on-call roster is, I mean, like the service is available 24/7 on weekends or also after office hour or just during office hours?
It is available 7 days, maybe not 24 hours, but it is available 7 days lah. So we also have people roasted on public holidays, Saturday, Sunday. Of course, you can have that.
Okay. All right. Thank you, Dr. Has. Any questions from the floor? Yes. Tuan Shamil has questions. In gray area cases where ethics and legal can give a firm yes or no, does the final call fall on the attending doctor or HOD? If so, is it necessary to document that the final decision was a group consensus?
So I think a very good question, Shamil. So of course often we have cases where you will have gray areas here where ethics can't give you a firm answer, legal also can't give a firm answer. Of course, the final call is lies on the treating physicians. Okay, whether the doctor itself ataupun if they involve the HOD. Basically, it's involved in the treating treating physicians lah. But then, of course, it needs to be documented. Okay, I will advise or I will recommend to group or to document it as a group consensus instead of just a personal decision.
Okay. Right.
Thank you, Shaman.
Okay, thank you, Dr. Has. Okay, if there is no more questions, I think we can end here. But if audience have any questions or concerns regarding, or if you want to seek advice, you can always contact us at the on-call roster, or just contact any of the medical ethics and law department members or any clinical ethics consultation service members. All right, with that, thank you everyone for attending. We will share the meeting attendance. Yep, pautan jam latihan telah di-share dalam chat box. Please fill in. Yeah, is available for 5 minutes only. Or you can use the QR code displayed. Okay, thank you everyone. Thank you, Has.
Thank you. See you.